All right, today I want to talk to you guys about acute kidney injury. This is going to be one of the most common diagnoses that you're going to be dealing with in the hospital. And so I just wanted to give you my basic approach to acute kidney injury. So let's get right into it. So first, we're going to talk about acute kidney injury. And just starting off, I want to talk really quickly about the definition of acute kidney injury. And so there's basically three criteria. And number one, and this is going to be the most common one, is that when your creatinine is greater than 0.3 from your baseline, then that's considered an acute kidney injury. For some patients, they have a low baseline creatinine, and so it might not be that accurate. So in those patients, you could actually use a creatinine that's greater than 50% of their baseline as an estimate for AKI. And then finally, this is a less commonly used metric, but if their urine output is less than 0.5 cc's per kilogram for 6 hours, then that can be considered acute kidney injury. And now let's just move straight into the kind of schema that most of you will probably be very familiar with from medical school. And this is one of the first schema that you learn, but it's prerenal, intrarenal, and postrenal etiologies of acute kidney injury. So let's just really quickly go through the different causes of a prerenal AKI. The first one is going to be true hypovolemia. So the patient is actually dehydrated and volume down. The most common causes of this are going to be from GI losses, for example, nausea or vomiting or diarrhea. And then also poor PO intake. And a lot of times patients will have a very clear history of this. So this can make this diagnosis particularly easy to make. And then also hemorrhage is going to be kind of our last one. So if a patient is continuously bleeding somewhere, they're obviously going to be losing volume. And so they're going to develop a prerenal AKI. But there are some situations where you actually have an adequate amount of total body volume, but the kidney is not really going to be seeing any of that. It's not going to be getting well perfused. These are conditions that we call decreased effective circulating volume. The most common cause of this that we're going to see is going to be from sepsis. So imagine that you get this infection, you have all these toxins that go to your blood vessels and your capillaries. They cause them to become very leaky. So all of your fluid in your body kind of just third spaces. It goes out into the periphery, becomes very edematous, and you don't get good blood flow to your kidneys in that situation. The other couple of situations are if you have systolic heart failure or cirrhosis. And these syndromes are going to be called, for heart failure, cardiorenal syndrome, and for cirrhosis, hepatorenal syndrome. And so these are both situations where you're actually total body volume up, but in heart failure, you have a poor pump function. Your heart's not pumping blood forward very well. So all of that blood will back up in your venous system. The other thing you get is this kind of venous congestion picture where you have just so much edema and volume overload that it actually becomes more difficult to pump blood forward to your kidneys as well. And then for cirrhosis, hepatorenal syndrome is when all of the blood is going to be basically collecting in your GI tract. So you get the splanchnic vasodilation due to nitric oxide. That causes a lot of pooling of blood into your GI tract. And that basically is not going to be seen by your kidneys, so your kidneys are not going to get well perfused. Finally, I want to talk about the last big class, which is going to be medications, because we have a lot of medications which can cause a prerenal AKI. The most common offenders are going to be things like NSAIDs, IV contrast, and then some less common ones are going to be calcineurin inhibitors, like tacrolimus and cyclosporine. This isn't really a medication, but hypercalcemia can also cause a prerenal AKI. Diuretics, and then ACE and ARBs. So the big thing to note for these kind of first four right here, NSAIDs, IV contrast, calcineurin inhibitors, and hypercalcemia, is they all really mediate a prerenal AKI by renal vasoconstriction. Most notably, like for NSAIDs and IV contrast, they cause constriction of the afferent arteriole that's providing blood to the glomerulus. And so basically, you're constricting the blood flow to the kidney. Therefore, you get a prerenal AKI. For diuretics, it's pretty self-explanatory. So you're basically causing somebody to become dehydrated if you overdo it. And if your total body volume goes down, then you're going to be having a prerenal AKI. And then ACE inhibitors and ARBs can cause an increase in the creatinine, mainly because of dilation of the efferent arteriole, which causes the glomerular filtration rate of the kidney to go down, so that basically the creatinine value will go up. The big thing regarding treatment of prerenal AKI is that usually you're going to try a fluid challenge. damage, with the exception of cardiorenal syndrome or hepatorenal syndrome. And usually you get a pretty good history of a prerenal AKI, you give them some fluids, you see if it improves. And some other clues that it's a prerenal AKI. So you're going to be looking for a BUN to creatinine ratio greater than 20. This is classic. Why do you get this? It's because when your kidneys think that your volume is down, they're going to try and hang on to sodium, they're going to try and hang on to urea, and by pulling in those solutes, they're also going to be pulling in more fluid to try and hang on to more fluid. So basically your kidneys themselves are not damaged, they're still working and able to retain solutes, and so you get more BUN, and so you get an elevated BUN to creatinine ratio. And then in that same vein, you're holding on to sodium, right, in order to increase the total body volume. So this is why your fractional excretion of sodium is going to be less than 1%, and then the Fe urea is going to be less than 35%, and then your total urine sodium is usually going to be less than 20 as well. So next, we're going to move on to a postrenal AKI, and this is very, very common. But basically, you have an obstruction somewhere down the line, and if the ureter is blocked, the bladder is blocked, anywhere along the drainage path of urine, then it's going to back up. It's going to cause dilation of the ureter and also dilation of the kidney called hydronephrosis. And then you're going to get a postrenal AKI because there's a lot of pressure and the kidneys won't be able to do their job anymore. So most common causes of this are going to be really like BPH, so very big prostate enlargement, kidney stones, masses or malignancies. Also, neurogenic bladder is another cause. The key things that I want you to know for here is that if a patient is urinating, that does not mean that they don't have a postrenal AKI, because they could have unilateral obstruction on one ureter and they could still be having a postrenal AKI. So even if urinating, still you want to get a renal ultrasound. One of the things I actually was looking up recently is just kind of the easy process of doing a point of care renal ultrasound, and it's really simple. You just point the probe marker to their head and then you just take a look at their kidney and see if you see any hydronephrosis. We're only going to really get better at it by practicing it. And so the more we can do point of care renal ultrasounds, the quicker we can get some preliminary data before we get the formal renal ultrasound. And so that's something you can definitely work on during residency. The other thing that I want to mention is that if you see a ureter on any imaging, then that means you have some kind of hydroureter, okay? So ureter equals bad if you can see it on imaging. Post-void residuals are also very good in any patient that you think has really bad like prostate hyperplasia. And if they have a lot of urinary retention in their bladder, our main treatment is going to be a Foley catheter. All right, so that's going to be the main thing. So number one point there really is renal ultrasound, even if urinating. If you think there's any suspicion for a possible post-renal cause of AKI. And then finally, I want to talk about intrarenal AKI. And so this is really where the money's at. This is going to be where a lot of the interesting and kind of crazy diagnoses in nephrology are going to be found. Usually what I first do is I'm going to rule out the pre-renal AKI, rule out the post-renal AKI. And if none of those are positive or I don't have a strong history, that's when you're really going to be thinking about, is there an intrarenal or intrinsic cause of the AKI? And the number one thing that you can do right off the bat when you're considering this is that you want to get you want to spin down the urine. So spin the urine. And this is really important. Basically, when I was on my nephrology rotation, this was basically called the liquid gold or liquid biopsy. And it really tells you a lot about what's going on with the patient. The easiest way to do this is you just kind of go ask the nurse for them to collect a urine sample, right? Got some urine sample. Then you go down to the centrifuge, you take a tube and you fill it up to about 10 millimeters. You spin it for 5,000 RPM for about 5 minutes. And then this little pellet is going to form at the bottom. Then get rid of all this fluid and you'll have like a tiny bit of fluid in the bottom. And then you just kind of resuspend it in there. And then after that, you're just going to take a microscope slide, put a couple of drops there, and then put a microscope cover on it, and then you're going to be able to take a look at what their urine sediment looks like. So the reason this is so helpful is because there's so many different casts that you can see that are really going to help you tremendously in figuring out what the etiology of their AKI is. So some of the casts that you may see, I'm going to show a picture in a little bit, but one, it might be a Hyaline Cast. And basically, if I see this, I'm thinking, okay, this is kind of bland. This might be a prerenal cause of AKI instead of an intrarenal cause. This is basically just this TAM horsefall mucoprotein that's produced by some of the tubular epithelial cells. And it just causes this, basically what I think is kind of this clear, glassy appearing cast that really is very nonspecific. Now, on the other hand, if you start seeing granular casts or muddy brown casts, or if you see renal tubular epithelial cells or RTEs, then this is all going to suggest acute tubular necrosis. So you can see already how just going off the cast can really narrow down your differential very quickly. If you're seeing white blood cell casts or eosinophiliuria, then that's really going to be suggestive of acute interstitial nephritis. And then finally, if you see anything crazy like dysmorphic red blood cells or white blood cells, basically they have like a Mickey Mouse appearance, or they just have little blebs around them. That's basically because they're getting squeezed through a dysfunctional glomerulus and then they look really weird. Or you see red blood cell casts, that's all going to be leading you down the route of glomerulonephritis. All right, so let's just take a quick look at some images of these findings. So first, you may just see some squamous epithelial cells. They're kind of these rectangular shaped kind of things like this, just basically from the skin pretty much. And then you may see renal tubular epithelial cells. Remember, this kind of is going to be going with ATN. And in my opinion, they kind of look like these fried egg appearance kind of cells like this. You might see regular red blood cells, which could be anywhere in the urinary tract, right? So they could have a urinary tract infection, they could have kidney stone that's causing this. But if you see dysmorphic red blood cells, and this picture is not very clear, but you may see kind of a Mickey Mouse appearance where there's like some blebs coming off, then you're really thinking about glomerulonephritis. Red blood cell casts, again, is going to be suggesting glomerular disease. White blood cells, not super specific because it can be just any signs of inflammation in the urinary tract. But if you see white blood cell casts, this is really going to be suggesting acute interstitial nephritis to me. Hyaline Cast, like I told you earlier, just kind of this amorphous, this casty looking thing, but it's very clear. Like there's not that much stuff going on in there. And, this says any type of renal disease. But if I'm only seeing Hyaline Cast, then I'm really thinking kind of prerenal at this point. But once you start getting granular casts or muddy brown casts, so like look how many dots there are in here, right? It's just like a lot more active. Things are going down. And then you got muddy brown casts, which is the classic term you're going to remember for ATN. Then all of these are going to be indicating ATN as well. And then finally, you may see some crystals, bacteria. These are some other things that you may see on urine microscopy as well. So this is why urine microscopy is really the liquid biopsy, because it can really give you so much detail and really help you narrow down the diagnosis a lot, just with a very simple procedure. All right, but going back into intrarenal causes of AKI, the way that is really makes the most sense for breaking this down is just going through the nephron and basically going through the different components of it and seeing what part can be inflamed or broken, right? So the first part is going to be vascular. The second part is going to be interstitium. 3 is going to be glomerular. And then 4 is going to be your tubule. All right, so I'm just going to go pretty quickly down the list of different things that could cause these problems. So vascular, you could have an infarct. You could have vasculitis. For example, polyarteritis nodosa, Takayasu. You could have a dissection that's kind of affecting the renal artery, antiphospholipid antibody syndrome, scleroderma renal crisis, and atheroembolic phenomena. For interstitial, you're really going to be thinking, of course, acute interstitial nephritis. Again, you're going to be looking for those white blood cell casts, eosinophils, sterile pyuria, so basically you have white blood cells but no bacteria. Most common culprits for this, there's a ton of them. So really good to know the list of medications that could cause this. So NSAIDs are a huge one. PPIs, also very, very common. Any sulfa drugs, antibiotics, checkpoint inhibitors, immune checkpoint inhibitors, especially with a lot of the new patients on these new chemotherapy drugs. And you can also just see it with patients who have recurrent pyelonephritis. All right, so very important to know what are common causes of acute interstitial nephritis. For glomerular disease, really you're going to be looking at 2 categories. It's going to be nephrotic syndrome or nephritic syndrome. And I'm going to do a completely separate video for that because it's a whole topic in and of itself. But really, things that are going to be suggesting glomerular disease are going to be proteinuria, especially when it's greater than about 2 grams per day. Because other AKIs can cause some proteinuria, but if it's greater than 2 grams a day, that's much more suggestive. Another finding that's specific is a urine albumin to protein ratio of greater than 40%. And then any of the casts that we discussed above, so RBC casts, dysmorphic RBCs, hematuria, things like that. All right, and then lastly, we're going to look at the tubule. And so most commonly, I'd say 90% of the time, you're going to see ATN. And of the intrinsic causes, this is definitely the most common cause as well. And one of the important things to note about this is it could be either ischemic or inflammatory. So for example, if somebody has sepsis, A lot of times they come in, they're very hypotensive, and so we say ischemic ATN, right? Their blood pressure dropped really low, their tubules kind of died off, they got necrotic, and that's why they have the ATN. But sometimes even in the absence of hypotension, low blood pressure, they can still have ATN from just inflammation and inflammatory process in general. So sepsis, even without hypotension, can cause ATN. There's also a lot of medications that can cause acute tubular necrosis. One of the common ones that you learn in medical school is going to be aminoglycosides. Vancomycin is a common combination that we're going to see causing acute kidney injury. And then a lot of different medications can cause crystalluria. And that's going to be like acyclovir, cisplatin, methotrexate, and ciprofloxacin. And those crystals kind of precipitate and they cause tubular necrosis as well. And finally, some other causes: multiple myeloma, tumor lysis syndrome, and rhabdo can all cause acute tubular necrosis as well. All right, I know it's a busy slide, but this is really the basics of how you want to be kind of categorizing and kind of compartmentalizing acute kidney injury in your mind. So you start off with prerenal, intrarenal, and postrenal. We have multiple different causes for prerenal AKI and postrenal AKI. And intrarenal AKI really is best served when you divide it into the different areas that the nephron can be affected. So the blood vessels, the interstitium, the glomerulus, and the tubule itself. And really the big thing here is that you want to spin the urine and get a liquid biopsy to really help narrow down your differential. And real quickly before we finish this video, so we kind of mentioned this earlier, but one of the reasons we get the fractional excretion of sodium is because in intrarenal, it's thought that usually the kidneys are damaged. They're not able to hold on to sodium anymore, so you're going to be dumping that into your urine, right? So your FeNA is going to be greater than 2%, which helps you differentiate it from prerenal. You can also get Fe urea, which is for patients who are on diuretics, and greater than 50% is going to be suggestive of intrarenal AKI. Urine sodium is usually going to be greater than 40. One of the big things that you should know is that really the fractional excretion of sodium is not a good test. It's really a test that was only evaluated in oliguric patients. It was a trial that only included like 17 patients. And in general, I really very rarely get a FeNA or Fe urea because for me, it really doesn't help me narrow down the differential that much, and it doesn't really change my management, right? Prerenal, I'm going to have a good story for why they could have a prerenal AKI. I'm going to give them some fluids and see if they get better. If I'm suspecting intrarenal, at that point, I'm going to be getting a urine microscopy. I'm going to spin the urine and I'm going to try and figure out other causes of their intrarenal AKI. And I'm going to see if they have ATN, right? So how does the FeNA really help me? I don't really see a huge benefit to it. And I'd say that a lot of nephrologists that you talk to will also say pretty conflicting things about the utility of getting a FeNA. And the way you get a FeNA, by the way, is you get a urine sodium and a urine creatinine, and then you just put the numbers into MD Calc. But in my opinion, you should know, what the different FeNA values are for prerenal and intrarenal, but really it's not going to be, and it really shouldn't be a super high yield test for you. And it's even in the kind of choosing wisely campaign of things we do for no reason. Another interesting point that you really should know is that GFR is not accurate in the setting of an AKI. All right, and this is an important thing that comes up a lot because say, for example, somebody's creatinine is 1, and then the next day their creatinine goes to 2, then your GFR probably is going to estimate it, your GFR is like 45 or something, right? Because their creatinine's 2. It's all based off these computer calculations and computer models. But in reality, that patient that went from 1 to 2 probably had 0 GFR for that day, because to jump a whole point in creatinine usually takes a very, pretty much no GFR, right? That's kind of the upper limit of how fast your creatinine can rise unless you're having like massive rhabdo or something, at least within 24 hours, right? So if you're dosing drugs based off their GFR that's calculated, you have to realize that it could be inaccurate because their creatinine is only 2, but really their GFR is 0, right? The other thing to note too is that urine protein to urine creatinine ratio is not accurate in the setting of AKI either. And so you should be really careful when you're trying to interpret a urine protein to creatinine ratio in the setting of an AKI, because it could falsely let you think that somebody has nephrotic range proteinuria, for example, but it's going to be falsely elevated when they're having an AKI. You have to be careful with getting urine protein and creatinine ratio because if somebody's just having an AKI, you get it and you see nephrotic range proteinuria. Now, when somebody looks at that, 10 months from now or 2 years from now, they're going to see nephrotic range proteinuria. And if they don't look to see that the patient had a concomitant AKI at that time, they're going to be like, oh, wow, this person's had long-standing nephrotic range proteinuria, so this is no big deal. But this potentially could be, this new AKI that they're having could potentially be a nephritic syndrome or glomerular nephritis. And just because you have that previous inaccurate value, you could really throw people off, right? So you got to be really careful with getting a urine protein to creatinine ratio. That was a bit of a little complicated explanation there, but I could definitely talk about that more at some point. So urine protein, just know that urine protein and urine creatinine ratio is also not accurate in the setting of AKI. All right, in my next video, we're going to be talking about nephrotic and nephritic syndrome and just basically the glomerular nephritides in general. So hope you tune into that video. Hope this was a basic overview for you of acute kidney injury and how to evaluate it and what the utility of doing certain things is. And I hope you enjoyed. Thanks for watching. I'll see you in the next one. Peace.